Every time you take a step, the full mass of your upper body descends through the spine and strikes the center of the pelvic ring. The common analogy of a static, bony bowl overlooks the intense mechanical stress this structure must redistribute to maintain a bipedal posture. Architecturally, the pelvis functions as a specialized bridge, engineered to catch the axial load of the torso and transfer it outward to the appendicular skeleton. The forces converging at the lumbosacral junction require an interlocking design that can withstand shear without shifting. We can only understand this stability by deconstructing the pelvis into its developmental components. This analysis follows a structural sequence, fusing the isolated bones, installing a central keystone, and locking with active ligamentous tensioners. Pelvic osteology represents a refined biological response to the mechanical stresses unique to the human gait. The adult hip bone begins as 3 distinct developmental units. The blue ilium forms the flaring superior portion. The green ischium forms the posterior inferior unit, marked by the thick ischial tuberosity. This tuberosity bears weight when seated. Anteriorly, the red pubis utilizes its rami to close the pelvic ring. A lateral view reveals all 3 bones converging within the deep horseshoe-shaped acetabulum. The acetabulum functions as the primary socket for the hip joint. During adolescence, the central triradiate cartilage ossifies, fusing these separate components into a single, seamless bone. The resulting topography of the adult hip bone preserves the record of these 3 specialized units, merging into a single load-bearing structure. Placing the left and right fused hip bones together in space reveals the structural requirements of the posterior pelvis. These lateral bones cannot support weight in isolation. They require a central keystone to close the gap and complete the ring. The sacrum, composed of 5 fused vertebrae, drops precisely into this posterior space to lock the 2 ilia together. These contact points form the sacroiliac, or SI joints. These synovial joints are rugged and irregular, optimized for absolute stability rather than a wide range of motion. We see a different connection at the front of the pelvis, where the 2 pubic bones meet. The pubic symphysis joins these bones with a fibrocartilaginous disc, providing the shock absorption necessary for the anterior ring. This completed bony architecture creates a continuous bridge, allowing the weight of the spine to be distributed laterally toward the lower limbs. Even a completed bony ring cannot withstand the significant shearing forces generated by human movement. Under a vertical load on the 5th lumbar vertebra, the top of the sacrum naturally tends to tip forward, rotating away from its ideal alignment. Biomechanists refer to this specific forward tilting motion as nutation. The deep interosseous sacroiliac ligament provides the primary defense, binding the bones directly within the joint space. However, spinal torque requires secondary anchors. The sacrotuberous ligament bridges the lateral sacrum to the ischial tuberosity, firmly holding the sacrum in place against downward force. By anchoring the sacrum to the sitting bone, it counteracts the upward rotation of nutation. Deeper still, the sacrospinous ligament extends to the ischial sign, providing the secondary anchor. These ligaments act as active mechanical tensioners, ensuring the sacrum remains locked within the pelvic ring even under maximal axial loads. The installation of these ligaments fundamentally changes the posterior contours of the hip bone. On the bare bone, we see 2 deep, open C-curves known as the greater and lesser sciatic notches. When we add the ligaments, their paths convert these gaps into enclosed loops. Anatomically, these newly formed openings are the greater and lesser sciatic foramina. These foramina serve as protected exit tunnels. The most prominent occupant is the sciatic nerve, which utilizes the greater sciatic foramen to safely reach the posterior thigh. This design achieves total biological efficiency. The same ligaments required for skeletal stability also define the safe routing for the body's largest nerves. Viewing the pelvis from above reveals the pelvic inlet, the circular border separating the upper abdominal region from the true pelvic cavity. The dimensions of this ring reflect a compromise between the mechanical efficiency of walking and the spatial requirements of childbirth. The thick male pelvis is optimized for weight transmission, featuring a heart-shaped inlet and narrow subpubic angle. In contrast, the The female pelvis is adapted for internal capacity, with a wider oval inlet and a subpubic angle exceeding 90 degrees. The rigid nature of the ring means high-energy fractures often shatter the bone in multiple locations simultaneously. These structural failures place the dense vascular networks within the sciatic foramina at immediate risk of hemorrhage from sharp bone fragments. Clinicians rely on these structural landmarks daily, using the ischial spine and sacrospinous ligament to accurately locate the pudendal nerve for labor analgesia. Understanding the relationship between these bones and ligaments provides the mechanical framework for analyzing human locomotion, managing safe childbirth, and prioritizing trauma interventions.